everyone, it's Liz. This is part 2 of the interview with my mom, who is also a nurse. So she's been a nurse for, well, you can do the math. When did you graduate from nursing school?
In 1982.
There you go, think about that.
Back when the dinosaurs rolled into nursing.
So we've been doing an interview session with her. We did part 1 and then it got really long, so we're just chopping it in half. So this is part 2, welcome. So we're just going to jump right into this. Oh, and I'm a nurse too. So that's what makes this fun. Have you ever worked with PAs, and what are your thoughts about PAs?
I have actually not worked with PAs. Like I said, we did not in any of the practices I had. We always had nurse practitioners. And I think because for gynecology and obstetrics, some of them came out of the OB world or a surgical background, I guess. I don't know. So I actually never did. Had a lot of orthopedics procedures, and I've had some PAs, like with all, who have been really good, and some who were less than empathetic. But that could have just been an orthopedic thing.
Yeah, I think that is partly an ortho thing. Ortho people are
not always the most empathetic people. So I guess our new practice where we're residing in Pennsylvania had a PA, has a PA that I've seen, and she's been very nice.
2 quick notes. So if you haven't seen part 1, it goes into a lot of like what her background is, so that'll make more sense. So go watch that. I'll link it up here before you watch this. And yeah, I forget what my point 2 was, so we won't even worry about it. What are the qualities of a good nurse in your opinion?
I think I put you had to be empathetic. Like I said, I think that makes a big difference. People are going to respond to you better if they sense genuine caring, because in the first video we talked about telling them no, but at least they have to feel that you really have their best interest at heart. What's really best for them, because if they don't sense that, they're not going to come on board with anything you're going to try to do. I think you need to be really knowledgeable in your field. I think you can practice so much better if you stay up with the developments and the research and things like that, because you really can't make good decisions just on how to foresee problems or ensure the best treatment plan is going forward if you honestly don't understand your specialty area. So I think that and then I think just be a motivated nurse, because nursing takes a lot of energy. You don't have it all the time, but you're there to help your patients, and that I think I know a lot of people who are tired. Some, not tired, but just that's why I'm not working on it. You sometimes we're out. You just are like, oh, I need a little break.
And if you're going into it just thinking like, oh, I just need to get through these 8 hours every single day, like that's probably not the job for you.
Because you're gonna have those days, and I've certainly had them, but that probably is not your everyday mindset.
Yeah, I think you have to have a pretty decent work ethic. I mean, even to get through school, you have to have a good work ethic. And you had said too that someone willing to be like a patient advocate.
Correct. Going
along with like being knowledgeable. You have to be knowledgeable so that you can advocate, and then you have to be willing to be that person, which can be.
Yeah, which is if you've done it, it can be very challenging, because it's not hard. It's very difficult to stand up when you know that the care, to discuss it with your physician and say, what about this, or whatever, because you're going to step on. And not only that, too, you have families. Families are often enablers, and it's very difficult to say that might not be the best for the patient.
Yeah,
and I'd be really thought what's best from their perspective, and that's hard, especially as you deal with older patients. Every family member wants their parent, their whatever, to be so-called fixed. Sometimes we can't fix them, so that's hard. Yeah, I think. But you have to. You're advocating for that patient sometimes, and sometimes they'll tell you things, and they want you to intervene for that in their family, because they are in a position where that's very difficult, whether they're young, old, or whatever. Often, and that.
You get told that a lot as a nurse. A lot of times you'll be in the room with them and they'll tell you like, I don't want that, or like, this is what I want, but they will remain totally silent when the team, especially if you're in the hospital, or even out, like when the whole group is standing there, because you have the attending, the residents, the entire room is filled with these other medical professionals, and then the family and the patient won't really say anything, so then you have to kind of be that person to be like, and it's hard, it's awkward at first when you first start doing it, because they're all standing there very authoritarianly, and you're sitting. Usually the patient is sitting, which I always think is hard too, so they don't feel at all like they can say anything, and you're over in the corner by your computer, and then usually at the end of the thing when they're like, all right, you have to be like, like, okay, I know you said all that, but they don't want any of it.
Right, or even,
or even correcting them.
Yeah, just in
not
triage.
Correcting, but just like inserting your opinion can be touchy.
Yeah, so I can't tell you how many times on triage you would get a call for women's health, and they'd be like, like not doing it. Like, well, why are you not doing it? Well, because that was the doctor's idea. I didn't want to do it. And he would say, did you express that? Well, no, I wouldn't tell them that. But you are hating it. You don't want to follow through on this plan. So it's not working. And it's not working because they were never on board with their treatment plan in the first place, but they find it difficult. So then you became the middle person and saying, can we come up with another plan? The patient really is not going to go forward with this. You can schedule that surgery. They're just not going to do it. So let's do something else.
You're the middleman a lot as a nurse.
Right.
I feel like you send a lot of pages like, hey, you know that plan you two just came up with? They're not doing it.
They're not on board. But it is intimidated. Most people are intimidated by health. It takes, not all, but a lot of people.
Even as a nurse, it's intimidating because you're the one in the room that has to be the fish going the wrong way in the stream. You get used to it though, you'll be fine. The residents, I always reminded myself these people won't ever see me again in 6 weeks because they'll be on a new round. So it's fine. What do you remember most about nursing school?
Well, that was a while ago. Just those nursing instructors and watching your instructors, I mean, they haven't changed in 30 some years. Most of them were very, very not nice. But we did have a few, and it's just amazing how much you learned from those really nice instructors. But that hasn't changed. What else? At the time, since we were doing that BS, our degree, the nursing staff there, they had their own diploma program at the school where we did most of our clinical, and they did not really care for us because most of them had graduated from that school also. So that was always a secondary challenge on top of that.
In our last video, we talked about ice cream, and that's how she and her best friend coped. They would go to clinical.
Friendly's ice cream on the way home. Especially if we'd been in the ICU with the director of our program.
What's different from your nursing school experience than you saw in mine?
I just think the technology, the use of it, the sim labs I thought were great because there were no sim labs. So you did everything for the first time, practically on a live patient. I mean, you could practice somewhat. So I think those were good. And just the tools available to you, like we had to use PDRs. You remember? Do you know what those are? PDRs? They're ginormous books with all the medicine in it. You could spend forever looking it up. And if you needed a quick answer on the floor, you had to go find it. So just having like Hippocrates, that's what I used to use in the office and stuff like that. Just those things, I think, because there's so much knowledge of those things are just available.
Yeah.
And make it much easier, I think. The study guides that come with your books, so all that's online. I mean, we had to log every single book. So if you were in clinical, you couldn't take your resource material with you.
Yeah. You're
not taking your huge med-surg thing.
And do you think it's more research focused now? Like how I had to do all those journal articles?
Yes, and the reason was because you have access to those journals. We had to go to the library and put in your journal requests in person, and then they would pull them from the different larger libraries around the state. And if you procrastinated, well, you were sunk.
And then she had said too, it was interesting how the programs themselves, since she was in a very beginning BSN, well, it was a BS, it was a bachelor's of science. Now we have a BSN, and hers was a bachelor's of science, and her concentration was nursing. So similar, but still different. So hers, since it wasn't a nursing degree, you had to take like calculus and physics, like all the upper level science classes, like as if you were a bio major. Whereas now they've pulled that back, and like we take nutrition, and you take more psychology, like things that are going to better you as a nurse rather than physics.
I think tailored it better because they were just getting started, so it was treated as a true science major, but I'm not sure that physics helped me as in any way.
What would the trajectory of the barf be to land on my shoe?
Maybe the mechanics should have helped in the OR, but I don't know. So I think that's better. The coursework is more tailored to,
like all the
nutrition would have been a great thing. That would
I feel like they should have more classes on nutrition, side note, because just in patient teaching, like a lot of it's nutrition. Did you want me to become a nurse, and why or why not?
No, I did not. I don't know. I said I think that nursing is a demanding profession, as many are, but I just, it's tough. Like we talked about, being the advocate, working with difficult surgeons, and you can see all that as a parent, and you think, do I want my child to fight those battles? Her dad's an accountant. He doesn't fight quite on those levels every day, but so I said no. But in hindsight, Elizabeth's done a great job with that. But you don't know that as your child is in high school. All you can see is like, and the nursing instructor. Cool. Right. So you kind of think, oh man. So I think as a parent too, sometimes you don't know what your child's capable of until they go off and try it.
Like, I don't think I would want, I mean, obviously she's 1, but I wouldn't want Avery to go into it until there was some serious reform. Just from like I experienced a lot of violence on my first unit, and I would never ever, I mean, knowing that, you wouldn't send your kid into that, like, go work on med-surg and yeah. Like,
right. And so I worked in the OR in a city too environment, and
yeah.
you know, what comes through those ERs and stuff. You're right. So you don't know, but
it all turned out fine.
Yep.
Were you disappointed I didn't become a doctor?
No. You know, I said I think doctors are important. They have their role, just like I think, you know, with all this time in nursing, that nursing provides just a great role for patients. You know, how many times did you get a call and say, well, why didn't the doctor explain it like that or tell me like that? I think nursing and medicine have two very different perspectives that they do, and both are necessary for patients to achieve health. But I think nursing provides, and our patients would just be, their care would just be so much less without knowledgeable nurses there to provide teaching and just someone to listen to and to present a different perspective. So
I think they're very complimentary.
Right, they are very complimentary, because I couldn't do the surgery, but you know, they couldn't do it without me. Our physicians could not handle the both. I mean, we were taking 600 calls a day in California. It was a large practice. You were not going to meet all those women's needs, but I needed to bring them in. They needed to be seen and evaluated, go to the OR, I mean, those things. So it provided a great working relationship together.
And we were talking about, it's interesting, I get asked that question a lot, whether my parents annoyed that I didn't become a doctor, or do I wish I had become one? And I think it's interesting that we view success in healthcare as being a physician, when like they're very, like, not everyone wants to become one, and you need both. So it's interesting that that is still on the pedestal of like, you've made it, versus like, I think a lot of people have made it in amazing ways as a nurse, like, and they didn't necessarily, you don't need to.
Yeah, and after having, I mean, you know, nowadays with all the insurance things that are put on how physicians practice and stuff, it is not like how they practiced when I first went in. They had so much autonomy and different things. Now I do not envy them.
The insurance companies tell you how to practice.
And with the codes and trying to get it all to jive. You're right, sometimes you're like, and where is your degree telling us who we can, you know, how to treat maybe gestational diabetes and just different things, because not every patient is the same. So I don't envy them that. The autonomy that they used to have over their own practice is long gone.
Tangent on that.
Yeah.
What is your most memorable story as a nurse?
Oh my gosh, there's a lot. I told him that first job, if you heard my other interview, we did a float pool right out of school, and I was up on a orthopedic or floor med-surg post-op, and I had somebody in halo traction. So you do rounds.
That's when your like head is stuck. Your head is immobilized
for a cervical fracture,
and it has these pins kind of sticking out of it.
Because we build the pins into the head.
2 poles.
And it goes around the head, all metal, to prevent the cervical spine while it's healing, fracture, so that it doesn't sever their spinal cord. So I did rounds, checked on him. He was all great, and then we're probably busy, so I probably didn't get back to like, I don't know, they were not quite hourly rounds, but to like 2 in the morning, and we couldn't find him. He was missing. He was AWOL. That was the cervical. So by the time we searched the unit in a flat panic, we couldn't find him. Had to call security. Try to explain to them what halo traction is. You won't miss him. So I had to go all through the hospital. Found him up on the roof.
It's like pre-camera.
Pre-camera, none of that. Pre-camera. Found him up on the roof. He needed just some time alone. He needed to escape. Fresh air. Up on the roof. So that paperwork.
Things like that still happen.
Still happening. Yeah, the other one, I think, I can remember saying, in the OR, patient coming down, taking him in, and they stopped. We had to stop. There was a traffic jam by the elevator. The woman bolted off the gurney, hit the button. By the time I got around, she got in the elevator closed in her little gown, just a gown, and you know how they come up, and took off down that elevator. So
bye!
Our OR was on the 13th floor. So I can remember going into the surgeon. We got a little problem. Gonna have to cancel. He wanted us to find her. But we're like, oh, that's a security problem. So those are 2 two that you can share, but there's just many. And there's, I think, the ones that I said we talked about, the non-happy ones that were at level 1 trauma center. I can remember some very, very specific cases that did not have an optimal outcome. I think if you've ever worked in the ER in open heart surgery, I said those are just beyond painful when we couldn't get the heart restarted and we were in there and just time. Those are, I think, two the sad ones. I think some of the people that you'll remember for your entire.
Especially with those, you do the whole surgery and then they're on bypass, and you don't know until the very end when you go to turn it back on, and you cannot get the heart to start beating again independently.
Yeah.
That's exact. I mean, you've done an 8-hour surgery on this person.
Or just whatever. And for whatever reason. Oh, those are just, people don't realize that, the surgeons, it was so hard on them, and just the anesthetist, send the fellow out to say, to start to prep it that things aren't going well while you tried everything under the sun, and it's just, that was very challenging.
Yeah, I think the funny happy stories and the really sad ones are usually the ones that you stick with. Like those are the ones that are stuck in my brain, and I'm sure yours. And you said too, out of that, out of the really hard situations, that is when you get to see everyone's, it is a team effort usually in healthcare, and that's a very good opportunity to see everyone's special, their skills shine.
Yeah. And you can see too the surgeons, sometimes thoracic surgeons don't show you a lot, but they truly were just devastated. And the anesthesiologists, you don't sometimes see that and the other nurses, how you work together.
On that happy note.
But you're all going to have that, right? Because nursing is full of those.
What are some of the biggest changes you have seen in nursing over the years?
Well, that would be just technology all around. I was just joking with her when I said when I started nursing, we had chest tubes that were made out of glass. Can you imagine trying to get your patient up and ambulatory with glass chest tubes? Yeah, you always lived on the edge here.
That's supposed to say laparoscopic.
Oh, and then and just from the OR, just the advances in laparoscopic and robotic surgery, man, just the time that's saved from patient recuperation and all of that, all those big items. So I think that was just types of that, just the medicines that are available. There's so many safer options. When I think about what we used for just sleeping meds, calcium, just many different choices out there that have so improved. I think I said the holistic approach to medicine. Back then it was just very cut and dry. Now we see, in OB we could have doulas in there, they could have their balls, they could sit in the tubs. That was just didn't happen back when Elizabeth was born. It was nice to see that there's a lot of different avenues. Midwives, we had in our practice down the hall, we had a whole group of midwives, so we could use them, and
I think that's much more accepted now, rather than being seen as frou-frou. Right,
and if they had a problem, they transitioned to ours, we transitioned back. I just thought that seamless work was just not there, and it was nice to see that was finally coming on board.
Yeah, and when I had Avery, it wasn't seen as weird at all that I went to a midwife, and
in Michigan they commingle their practices, which I thought was great. So if you had a problem, we would take you on, and then if it resolved, we'd send you back for them, or when we delivered you, if it wasn't really going to be a complicated thing, we would actually send you back for the postpartum visit, because that's who you'd start your care with and you'd wanted to see. So I think that was nice.
And then you mentioned surgical material, just the materials that you're able to, the stent, everything, the stents, the different things that you can put inside humans now.
And it goes
crazy.
Across the board. Just all the manner of stuff.
And then pain management and
that
end
had
of
been
life
really
care.
poorly done in the 80s and all the way to the 90s. Just the pain management, and how people are aware, and end of life pain management. That used to just be so heartbreaking to watch, and now they do so much better job just for patients, just comfort, and I just think end of life care has come so far. And so much more humane and dignified, I guess.
There's a lot more palliative care involvement now, but I do think we went a little overboard on pain management. Maybe in the beginning it didn't do well, and then we went a little too far.
Right. So
now we're having that whole opioid crisis, but I think it's more aware now. Even if you're not going to throw medicine at them, I think there's a lot more physical therapy and
and they could still
other ways
on that,
too.
Chiropractic care, just some non-traditional approaches. And I think that if insurance was embraced, acupuncture.
Now it is a vital sign. What do you wish you would have known as a new nurse?
Man, can't even remember. So I think that you just need to give yourself time to develop your own way of nursing. You know, you watch people do it around you. Sometimes you feel insecure, but we all develop an innate way that we're going to deal with patients and things. And I think you just have to give yourself some time when you come out or in your new job. You have to kind of find your way, what works best for you and how you're dealing with people. And I think that we feel like, oh, I'm not doing it well. And then when you switch any new field, you have to kind of redo that again. Like what, and then just to give yourself time to find that what works for you.
Yeah.
That makes sense?
Yeah, and you don't have to do what everyone else is doing. I feel like a lot on social media too, you see everyone goes straight to the ICU and does, you know, they're all in the cardiac ICU and doing these crazy things. But I think they're like, you have to find what you like. Like I never wanted to go to the ICU, you know, and I find like you don't have to do the flashy thing that everyone's doing, because there are a lot of nurses that are not ICU nurses that are great nurses. So, or OB, you know what I mean? Like you don't have to be in a specialty. You can be doing whatever you want to do without.
Yeah, and I think as you live life, your family's going to encounter nurses in many different specialties.
Yeah.
Like OB. Elizabeth would have been a C-section nurse except for a baby, except for a fantastic labor and delivery nurse who worked with me to get you delivered. And you know, I think you appreciate these things as your parents have surgery or your children. You see, there's so many good nurses in so many fields. There's really no one best. It's what works, what you really enjoy.
Yeah, and just kind of dabble. You said that don't be afraid to like dabble in new things. It's going to be hard initially, just like any new whatever, but
Like
there's lots to dabble in.
Right.
So dabble. What are your 2 favorite things about nursing and your 2 least favorite things? You didn't come, we forgot to write down her favorite things.
Well, then we'll do my least
We'll
favorite
do your least
thing.
favorite
I think
first.
that the least is just still a great lack of awareness and appreciation for what nurses really do for patients and how we can change their lives. And so as a nurse, you get the positive feedback. But society is still stuck on like that whole doctor question.
Yeah, why aren't you a doctor?
Yeah, something like that. But you know, as a nurse, you can see the impact you have, and you get those responses. And so I think there would be other people don't see it perhaps as much. What else did I put down there?
The lack of adequate
Oh,
staffing.
the lack of adequate staffing. Yeah, that one is still. I don't know any nursing that I've ever practiced with. That's not true. The OR, because of strict mandates of whatever, that is the one place where they actually have to have the standards met, because you can't run an OR without a circulating nurse in someone's script. So that's not that. I will say, I guess that we might have to pull a lot of overtime, which I guess we certainly did in our day.
But you wouldn't go like, and sometimes on the floor you can kind of be like, we're just going to run one short, and you're going to have 6 patients. You know,
so the
you'll
OR
have more patients.
had to be delayed.
Yeah.
You couldn't staff a room. You couldn't staff a room. So you might be overtime pulled to. They mandated a lot of overtime, but you still were going to have the 2 of you in there.
Yeah.
You just couldn't do the case without you. So I guess that was it. But that was the end of just one of my favorite things. I just think was the impact you have on people. You know, you can see how sometimes you can see the good you really do, and they're appreciative, and you can just make a difference. I think in their overall well-being, and their, even if the outcome maybe isn't always optimal, you can certainly help on any given day. You can make somebody's life better, and I think that's just one of the very rewarding aspects of it. Do you think?
Yeah, I think you, at least in my personal experience, you remember your nurses more than you remember your doctors.
Oh yeah,
yeah. You have to pick one more favorite.
One more favorite. I think that, you know, we talked about difficult coworkers, but over my lifetime of nursing, I have just worked with some amazing nurses, male and female. You know, they have a bond to stick together and defend their turf, so to speak, if that's the right word, but like no other.
Yeah.
I think they can be incredibly loyal and for you.
Bond over wiping some butts. Yeah. It's a challenging thing. I think anything you go through in a challenging, like high pressure situation, you're going to bond with them. And there are a lot of cool people.
Right. And I think nursing has, you know, some people work in offices and they really don't know about their life, but I think because of the situation, I think nurses, did we not all know about everybody's life?
Yeah.
We shared the life journey with our other nurses along the way.
That's one thing that Joe always says all the time. He's like, you told your coworkers that? Like, yeah, why what? Like, they know everything. So I think
nursing is a more professional.
Open up to people more, so you know them on a much deeper level than
some people
you would
work with. Right.
My dad, who's, I don't think he's probably talking about his bowel movements with his other accountants.
I'm not sure. but they certainly know about our life and our challenges and different things.
Why is there a lack of adequate staffing?
I think because there's no way often to justify a cost basis for the nursing care that we provide. You can't direct bill it. And insurance is all about our ICD-10 codes and this and that. So it's very difficult to account for and direct bill. Like the intangibles of nursing is very difficult. They're doing it more from a preventive standpoint in a sense, so that things don't occur, like med errors or whatever. They're not seeing it from how this so perhaps the study would be like, how does good patient teaching reduce the coming back in, or if I can bring them on board. But all that takes time and relationship building, and they don't see that as a good cost basis.
Task. Like you can't, when you chart, or even in the hospital, like you chart educated on, but you don't get anything. The hospital doesn't get anything for that. It's not a paid reimbursement. It's just you need to do it before they leave. But you get paid, for hanging a bag of IV fluid, or for doing dressing changes. That's a measurable thing that they can kind of justify. Like, you did these 5 tasks, but in reality, you're doing 12 other tasks. And like you said too, if you're on the phone with someone who's having a miscarriage, you aren't going to be like, oh, I'm sorry, but like I have to go, next call, bye. Like,
right. So you're going to be much more challenging in time. But that patient, they're going to cope better. Yeah. They're going to have a better feeling about your practice if you can empathetically deal with that. And those situations always take much
as
more
they
time.
Should take.
Right, because someone is having a very sad life event for them, and that's not going to be the same as, oh, I need my birth control refill.
Yeah.
Oh, hello. Well, that actually went to voicemail, so I don't need to talk to you now.
But things like that, and then it creates you're behind.
Right.
But like you said, you can't quantify. It's hard to quantify for reimbursement purposes to show like we need more nurses. So then you do spend the time with the people who need it, and then you just get behind on everything else, and it's a train wreck. Is there a specialty that you wish you would have worked in but never had the chance?
I think I put down maybe coronary care unit when I first came out. I really liked telemetry and enjoyed that. So, but then I went to the OR and I really liked it. So I really didn't have a desire to go back there.
She did what she wanted to do because she dabbled. There you go, life lesson. Last question: have you seen the nurse-physician relationship change over the years?
Oh yes. When I first went to work, we had to give up our seat if we were charting, and a physician required our seat. I kid you not. No, and we still wore uniforms. White uniforms with stockings. It was a Catholic hospital. We didn't even wear pants. And a navy blue sweater. And we gave up our seat. We felt it in advance we didn't have to wear the hat. So, yeah, so there was not a lot of back and forth. And now I think we have, it's much more, I think, collaborative. Not always, but I think they're much more amenable to listening to you when you present your reasoning and your thing. And I think too, like since I did triage, they knew that you were providing a lot. We had a great latitude of independent things that we could do, and then you had to come to trust and rely on you as you made plans and implement them that they really liked. They came to trust you, and so they allowed you that a lot more latitude. With how we provided patient care for them. So I think that's changed. That wouldn't have happened in the thing. But now I think that they're finding that, hey, we can, they have to let go somewhere. So I think they've come to realize the benefit of that they can trust nurses and they provide a worthwhile, benefit to their practice and their patients. I think our patients is becoming more the norm.
The more I think the probably interdisciplinary thing has probably.
Yeah, just not only that, we use dietitians with our gestational diabetes. They could
you never
really
did that before.
I mean, they totally relied on them, and they, just other things, right? So I think that's improved.
Families are involved a lot more now.
Oh yeah, in all aspects.
Yeah, but all right, yay! You made it.
Survived.
You did it. So thanks for watching, guys. Thanks for my mom. Thanks for doing our interview. Everyone should interview their mom. They learn some things. And
daughters.
But yeah, So if you're very new here, I am a family nurse practitioner. I do weekly vlogs, kind of like documenting my very new FNP role, and then a weekly nursing video like this. So you can subscribe below if you want to follow along with that. And on Instagram, I do like updates throughout the week on things like that. So, and we always have a question of the week, which I'll come up with this time since I threw you on the spot last time. But what
specialty might you want to consider?
What would be your, yes, what would, if you were going to switch specialties, what would be like your specialty that you would want to jump into? I like what I'm doing now. Had I stayed at the bedside, I would have wanted to, I always wanted to work in the NICU. And I found out I got a NICU job the day I found out I was pregnant. So I didn't go because I thought grad school and being pregnant and having a new job might just like put me over the edge. So that's my one thing I never did that I would have liked to have done, but it's fine. But yeah. Anyway, so thanks for watching. Make sure to go watch part 1 if you didn't catch that one, and we'll see you later. Bye. We've had one final thought. We've both changed, so you're just gonna have to do it in real normal people clothes. Look, we're not actually the same height.
Elizabeth's taller.
Her thought that she forgot, which is a very good thought, so I thought we would include it.
Yeah, my final thought was that as nurses, we need to be our own best friend to nursing, and we should share what we know, our knowledge, and save our fellow nurses from themselves and, you know, just from bad things. I can appreciate how much I learned from nurses over my time, and then, so pay it forward. I think that's the best thing we can give.
Be nice. Don't eat your young.
No, and help educate them and share your knowledge. I think that's the best thing to do.
Fun fact.